This session hasn't gone entirely as planned. We are actually down 2 panelists due to such reasons as medical emergencies. The three of us have had a conversation, and they're certainly very confident that they're going to make a go of it. And you all as attendees have been wonderful thus far in demonstrating your desire to engage with the panels. So with that said, allow me to introduce the moderator, Brendan Downing. He is a partner at Falcon Consulting Group, in which he's responsible for the leadership and strategic vision of the company. He brings an extensive background in health IT and has played a vital role in implementations at nearly 20 healthcare systems. So join me in welcoming Brendan.
Thank you. So as she mentioned, we have a kind of a light panel up here today. So we're going to try to make this as interactive as possible. This is a topic that really everybody should be passionate about, because at the end of the day, everyone's a patient or everybody is a family member of a patient. So we're hoping to have a really interactive conversation today. So with that said, I'd like to just introduce our one panel member, Heidi, and So Heidi, in your introduction, everyone has a different definition of what patient engagement is, and everyone has a different vision for how to better engage their patients in their communities. So Heidi, if you want to just start off with maybe an introduction of yourself, your organization, and then how you would define patient engagement.
Sure. Can you guys hear me? So I'm Heidi Albright. I'm the director of the Institute for Cancer Care Innovation at MD Anderson Cancer Center in Houston. And really, my background is in finance, healthcare administration, and most recently, public health. What I do at Anderson is I lead a very, very small group of people. There's only 8 of us. And we're really responsible for figuring out how do we improve the value of the care delivered at Anderson. So that's not only looking at outcomes of care, but also at the cost of care. And of course, technology kind of spans both of those. Disclaimer, I'm not a technologically enabled person. So if you have any technical questions, I will obviously have to defer those and get back to you. But today I'm here to talk about patient engagement. And the reason that I wanted to really come here and talk to you all about this is because over the years, we've made so many discoveries in terms of patient engagement in the work that we've done. Again, we've done work on outcomes and on costing, and really preliminarily, we were looking at outcomes more from a provider perspective. So we were looking at places like Cleveland Clinic, Roswell Park, that were publishing these really great graphics of Kaplan-Meier curves, and we thought, wow, is MD Anderson the #1 cancer institution in the country, maybe the world? What do we need to be putting out there for our patients to consume in terms of information that they might want to use when they're trying to determine how to get through their care planning process? So it was up to me to sort of form this group and start looking at outcomes and how we could better capture outcomes in our electronic medical records, how we could better analyze that information, and then how do we report it back and to whom do we report it to? So we started doing all of these different committees and workshops within our own institution. And really, we asked a lot of physicians. And at the end of a couple years, we had some really great data on what the physicians wanted in the medical record and the clinically relevant things that were important to them. And I think it was our chief nursing officer, Barbara Summers, who we were in a meeting one day, and she said, this is really great, but how do we even know that the patients want this? Oh, well, that's a good question. We kind of never asked them. So then we started down this journey of really trying to engage our patients and figure out what do they even want? So 2 years ago, we did a series of focus groups we did in 5 different cancers, and what we found really blew our minds. So you would think, we're at a cancer center. The first thing everybody wants to know is survival, obviously. What's my survival rate? In fact, our patients really don't want to know that. They come to Anderson because they expect that they're going to be the one that survives, and that's great. What they want to know is, in the middle of the night, when I'm sick, if I'm having a side effect from cancer, who do I call? Because I don't want to bother my physician. I don't want to bother the nurse. Who can I call to explain to me, how do I tell my 3 kids that are under 10 that I have colon cancer and I now have to have an ostomy bag? Who do I call to find out who can help me take them to school in the morning when I'm not feeling well? So it was all of these different things that we had not thought of in terms of being providers. And so that's really why I'm here today, is to try to really engage you all in conversations of, if you really want to know how to build these new electronic information exchanges that are centered around patients, it's better to just ask them. In fact, I got a tweet last night. I tweeted that I'd be talking about patient engagement today, and one of the women that I met last year at Stanford MedX said, well, I hope that there's patients on the panel. And I said, wow, that's a really good point. So I can also speak from the perspective of a patient, but obviously I come with a little bit of bias. So at that point, I'm going to turn it back over to Brendan, and we'll kind of open it up a little bit.
Sure, thanks. That's a great introduction. And I think it all goes back to, patient engagement is really centered around the patient care component and improving that. So at MD Anderson, what metrics do you use to engage or assess the level of patient engagement? Do you look at face-to-face time with the physicians? Do you evaluate the calls as you discussed?
So at Anderson, I think we've been really, really fortunate over the last 7 years. So we have a homegrown electronic medical record. We also have a homegrown patient portal. And 7 years ago, the decision was made to just turn it on and let patients have full access to it. So through our patient portal, our patients can actually access their entire medical record. So they see everything that the physician sees. There's a 7-day delay on testing and results. There's only 2 or 3 things that they don't have full access to, and those are ethics consults, psychiatric consults, and we turned off the live vital sign monitoring for very specific reasons. We thought that there would be a lot of issues coming back from the physicians, that they didn't want this, but in fact, we had absolutely no complaints really from the physician side. We think that it actually alleviated a lot of questions that the patients might have if they were questioning something in their medical record. But that being said, no, there's no specific way for us to monitor how long a physician's spending with the patient, so face-to-face time, nor do we even feel that sometimes that even matters. There's multiple reasons why a visit could be longer or shorter. What really is mattering is the actual things that are occurring within that visit. So it doesn't even have to be the physician. If the nurse is the one that's actually providing the pertinent information and doing the education and the teaching to the patient, maybe that's where the value lies in that. In terms of looking at how we monitor our patient portal, we actually do have analytics that come back on turnaround time. So we have a secure patient messaging system. So we do look at 24-hour turnaround from when a patient emails through that system to whomever is supposed to be answering it. So on the other end in the clinic, the patient can actually message either their provider, their physician assistant, their nurse, or their scheduler, or I think even also the financial office if they have questions about that. And so we do get reports back, and it's the job of the individual multidisciplinary care centers to manage that. And that gets reported back through our clinical operations. In terms of other things of patient engagement, we really, it's so difficult to measure those things because we don't even really know what it looks like. And I think right now, literally at this moment, we're kind of defining what does patient engagement look like, an optimal patient engagement experience. And like I've said before, it's going to be different, we know, for every patient. And that's because patients value things differently. They have different preferences out of their care. A colorectal patient's obviously going to have different outcomes than a breast cancer patient. And so we're really trying to be as personalized as we can in some respects, but then trying to figure out what's the general framework that underlies all of that. So short answer is we're working on it.
Great. You talked a little bit about patient portals, and I'm sure it's a topic that everyone's familiar with. I'd like to just get a show of hands for folks that either have implemented a patient portal at their facility or have used the patient portal from a patient perspective. Great.
That's awesome.
Great, yeah, that is awesome. So talking about patient portals and extending to that, That's one of your key strategies that you use for patient engagement. What are some of your lessons learned with implementing a patient portal program? You talked about just turning it on and letting the patients kind of drive some of that adoption. But what were some of your lessons learned, and what hurdles have you faced in the implementation or improvement of that patient portal?
Well, we are no longer sticking with our homegrown strategy, and that's really important. And I think if anyone's familiar with MD Anderson and we have a new president, we have a new chief medical informatics officer, John Frenzel, who's amazing. He's a practicing anesthesiologist who also has a degree and background in computer science. So we have a team, I think, assembled now that's really driving this strategy forward into the future. It costs a lot of money, obviously, to build it and maintain it on your own. We're definitely not in the software development business, and we're trying to move towards people that have expertise in that area. Lessons learned, really, I think what Kirk had mentioned earlier in terms of patients wanting to fix their information, I think that's huge. There's a lot of information that it's really no one's fault that it gets recorded incorrectly, but it does, and so patients want to go back and fix that. I think the other thing is that so I say electronic medical record, it's really a viewer, and it's sort of a aggregation of all these different best-of-breed systems that we have throughout the hospital. We still have a lot of scanned documents, so handwritten notes that are scanned through as PDFs that can't be digitized and read by anyone other than a human. And that's really limited our ability to do some retrospective analysis on things that we really feel are important. An example being, we were trying to do a study on breast cancer patients and determining, what outcomes are important to them. Well, a huge outcome for a breast cancer patient that's had a mastectomy plus plastic surgery is, do you like the way that you look afterwards? Well, nobody ever asked them that question. So we spent hundreds of hours combing through medical records to see if there was even an indication that that was even addressed. But that's huge. If you're a patient who's had a mastectomy plus plastic surgery, it would be nice if somebody asked you, were you happy with the results? So those are the types of things that we're trying to look at to build into our next generation EMR. Also, for other types of patients, when we were doing these focus groups, some of the patients said, I never realized how many friends that I would lose going through this process. Well, that's interesting because in that same focus group, people also said that they didn't want psychosocial support. Well, maybe it's the way that we address the question. And so maybe we need to start asking questions in a different way and making sure that the terminology is correct and that we're capturing it correct so that it can actually trigger something to happen. So if you have a patient that's saying X, Y, Z, in this context, does that mean that they probably need a psychosocial consult as well? And so we're trying to look for those triggers and really pulling from our clinical experience to figure out how do we trigger events to occur within the electronic medical record that can then lead to some retrospective analysis and even predictive modeling for what types of services are we going to need in the future for, as disease change.
Great. Looks like we have another panel member that joined us. Ingrid, if you just want to make a quick introduction of yourself and your organization, and then maybe talk a little bit about your definition of patient engagement.
I like to make a grand entrance. I'm Ingrid Anderson. I'm part of Christie Clinic. Christie Clinic has been one of the oldest continuous practicing clinics in the nation since 1929. I've been there for about 19 years now. I'm head of family medicine. I'm also the chief medical information officer there. And I flew in. We at Christie Clinic have we started an electronic medical record about 12 years ago. And then just this last year, we switched from that electronic medical record to the one we have now that we just literally went live 2 weeks ago. And so we've transformed from baby steps in electronic healthcare to a very robust system that we have now, which has taken us milestones from where we were just 12 years ago. And that's been an incredible journey for us. And so I'm here to answer any questions you might have.
Great. Thanks, Ingrid. So going back to what you were talking about, Heidi, you talked a little bit about those surveys, which I think are critical for gathering data in relation to how satisfied patients are with the care that was delivered. What sort of, you talked a little bit about incorporating that into your EHR system. What do you do with that data, and how does it shape clinical care in the future?
Well, there's several different types of surveys, obviously, that you can do. We do use Press Ganey, and that's more patient satisfaction. But maybe this is just where my opinions are my own. That doesn't really address the issues of the care delivery process. That's asking you, was the food good? Were the people nice? That's great. But I kind of want to know, did I achieve the outcome that I came here to achieve? So what we're trying to do at the moment is work with our behavioral science department. We have some tools that do system assessment and indexing of symptoms per disease site, and we're really trying to integrate those into the medical record, like I was saying before, to potentially trigger events to happen and to be able to do analysis. So if we start seeing that certain things that we're doing for certain patients are triggering XYZ symptoms to occur, again, as disease patterns change, as volumes change, we can then focus our efforts there. I think it's really important also from sort of a toxicology perspective. I mean, our researchers would love to have this information available with their hands, an epidemiological perspective as well. And then you can start really digging deeper and doing really so much better analytics just around your patient population in general. I did a study with my team there for head and neck cancer. We just got it published. It took 3 years to do. We spent over 2,700 hours abstracting data from 2,500 patient charts. And this is in our electronic medical record. I can't do that. I can't spend my time doing that for one paper. So I have to have better ways to get information quickly. And I think that that's really what's going to transform medicine really in the future, is putting this information back into the hands of the patients and saying, okay, this is what we have. Does this make sense to you? What can we do about it?
Great. Great. Anything to add, Ingrid, on that note?
Well, I think, the medical record used to be a big dark secret for patients. And it was something that the physician hovered over in the room, and patients never got to sit next to it, touch it, or look at it. And now the electronic medical record really opens it up and becomes a conversation tool for patients and the physicians. In our clinic, even before we took this next step and went to the even more robust EHR, what we have in my particular department, and primary care may be a little different from specialty care, but not that much. What we have, I have my computer system sitting on my desk, the patient sitting on the table, perhaps their partner maybe sitting next to me and looking over my shoulder, but we have a dummy computer sitting up there so that the patient sitting on the exam table can see what I'm doing, look at the lab results, look at the notes, look at me making out my prescription, so that they are involved the entire time they're in the office with me, seeing exactly what I'm doing, seeing exactly what I'm looking at. We have printers in all the exam rooms, so I can print out the notes, I can print out the educational material, I can print out copies of anything they want to see from me or from my colleagues, so that even if all my colleagues aren't as engaged in the EHR as I am, my patients know when they come to me, I can offer them everything they see. And that makes a real, some people are worried that when they're dealing with the computer, that their patients, that they're going to have their backs to them all the time. Well, if you do this kind of an arrangement, they are engaged with you from the get-go, and even though you may be typing into the computer, they're watching what you're doing up there all the time, and so they feel they're part of the process. So you're engaging with them even when you're not necessarily always looking at them and always talking with them. They feel they're part of it, and that's a huge step forward compared to what you used to do when you were flipping through the pages in the paper record. So the EHR doesn't necessarily disengage you. I think it really engages you if you do it the proper way.
Sure. So it sounds like transparency is very important.
It's huge.
Yeah. So is there anything from a transparency sake that MD Anderson does to, kind of like what Kirk was talking about earlier, giving patients, or with the HIPAA omnibus rule, forcing healthcare organizations to allow patients to view their medical records? Is MD Anderson doing anything above and beyond just that?
In fact, we are. So again, our patients have full access to everything in their medical record. Excuse me. We also have a portal where referring physicians also have the same access as MD Anderson physicians. So there's no delay on test results. There's actually nothing blocked out. Any referring physician that the patient allows to have access, and this is very important. So the patient has to say that, yes, this physician can have access to my records and it can be revoked at any time. That all happens. Above and beyond that, because of the work that we did with the focus groups a couple years ago, we actually were funded through the Arthur Vining Davis Foundations to do a more in-depth study on this issue of patient engagement, caring attitudes, outcomes reporting, et cetera. So we're working with the Arthur Vining Davis Foundations over the next 2 years to conduct more focus groups to really put some academic rigor behind what we think is correct, and really start accelerating that. And we're hosting conferences with them and really trying to get some of the major players in healthcare involved and looking at this is what we feel it's like, and it's not hard to do. It really, I mean, we've done it with a staff of, when I started, I was the only employee, so it was me, then maybe 3 people, then I hired some contractors to help us abstract, and then we expanded and contracted. Now there's 8 of us. It's really not that difficult to do. The other thing that we're doing that's very important is we're actually partnering with the ONC and RTI to look at how we get this information outside of MD Anderson, following all the rules that Kirk and Linda were mentioning. And this is a project that we're going to be working on over the next year to look at how can we make this information really more transferable and more interoperable. I think for the longest time we thought, we're MD Anderson, our information's here, everybody has access to it that wants it, so why on earth would we want to transport it to Health Vault? And then, I started doing some digging around and started looking at things like Health Vault and other applications like that, and realized there's so much more out there that MD Anderson cannot provide and will never be able to provide to these patients, like daily tracking and monitoring integrated with the information that's in our systems. So really, we're trying to study what's the best way to get the information that we have outside of MD Anderson, fully complying with the law, but making it so that patients can then take this and really have it be part of their everyday life. Maybe it integrates with something like Fitbit, or maybe WebMD or something like that, or their prescription application, or you can name your hundreds of applications out there that the patient can choose to put their information into, and it's just us being able to say, if you want this information, we have it, and this is the best way we can get it to you.
Great. So we talked a little bit, thanks for touching on the mobile app perspective, because I think that's another great way to engage a patient population, especially if it's interoperable with your EHR system. But what strategies do you think could be used to target the tech or health illiterate? There's a lot of people, particularly in the elderly or low income or other vulnerable population groups, that might not be able to use such things as patient portals or mobile applications. What solutions do your organizations use to engage those patients?
Well, I think Heidi's point was well put. The computers are dumb. They only do what you put into them and what you can glean from them. And I think every organization, whether it's MD Anderson or Christie Clinic or whatever organizations you all are working with, the personality of the organization is going to glean from the computer and put into the system what that organization has to give. What Christie Clinic did for several years now is we've drawn from what we call the lean process, and that may be something all of you are familiar with or maybe not familiar with. The concept comes from Toyota, the lean process. And basically it means that all of us within the clinic, whether it's the providers or the cleaning staff, or whether it's the nurses or the MOAs or whoever it is, we've all become part of the process of trying to make Christie Clinic a better place, a more efficient place to work in, a more congenial place to work in. So we've looked at all the processes throughout the clinic, from administration down to how we clean up after ourselves. And everybody is part of that process. And that has made a huge change in the camaraderie within the clinic, how we work with each other. And that also has changed how we approach the computer systems, how we care for our patients from the time they come into the door, from the time they leave. And that this is how we approach the entire care of the patient. This also affects how we involve patients in their own care. So we've had processes where we involve patients in mammography. How do we bring a patient in? How do we give them the news? We've involved them in these lean processes, so patients feel they're part of the process of how Christie evolves. And it's not just the staff and the providers, but the patients themselves who help develop these processes. At the same time, we've also looked at group healthcare sessions. Maybe some elderly patients are not terribly computer savvy, but maybe group sessions where they learn from each other are better ways to conduct some healthcare approaches, so that they learn from one another, maybe not from computer sessions online, but from other patients who have similar concerns. So that may be another approach that's a little more modern approach, but not totally online and tech savvy. And that gives them some other access to some other forms of healthcare. So that's some approaches we've taken to Christie.
And I just wanted to comment, that's exactly what I would echo, is that if you're doing things like lean, you definitely want to involve the patients, because just having a group of administrators or physicians sitting around saying, yeah, well, this process would be easier for me if we did this, this, and this. Well, we have no idea how that's going to affect the patient care delivery process. I did want to make a comment also. I'm sure some of you are familiar with the Open Notes project. And several years ago, we had the pleasure of having Tom Del Banco down, and we just did a really quick. We wanted to just gauge, how patients were using our portal, and we found some patients with our patient education office, and we had this really quick focus group, and it was really interesting because everybody there thought that they were there to learn how to use the patient portal. So it really turned into this sort of, okay, wow, we had no idea, everybody there had a username and password, but had they gone into it at that point? No, not yet. So we really felt, and we do feel like there needs to be so much more education on how do we use it and how to make it more patient friendly. If you're an MD Anderson patient and you have you can go into the portal, there's a calendaring system, there's secure messaging, and then there's this little button that you can barely see that says your clinic records, and you go in there and it's everything under the sun that you could ever want to see about yourself. But it's not friendly to anyone that would even know what to do with it. And so that's part of our strategy moving forward, is to make it easier to use. I would also say, in terms of health disparities, there's a whole huge discipline around behavioral science, around health disparities. I'm fortunate to be finishing up a master's in public health at Hopkins right now, and I have nothing but respect for the people that do this type of work. But they have learned so much about how lower socioeconomic status patient populations use technology. They did a study at Harris County Hospital System, and they said, okay, well, we're just going to start pushing out information to people on their cell phones. Well, that's great, except when people actually don't want cell phones. And they actually had to give them throwaway cell phones. So you have to start thinking in terms of, what does this patient population need, and what can they understand, and how do they want to give feedback, not just how you would prefer to receive it.
Great. Before we move on, does anyone have any questions or comments on patient engagement strategies? I see a bunch of hands, actually. This is great. Do you want to?
Are either of you doing anything on shared decision-making aspects, or on that one, relative to clinical options for care with patients?
Shared decision-making as in, you mean health with family members?
As in what course of treatment? Breast cancer, we can do breast removal, we can do radiation, we can do chemo.
No,
Pros and cons of each.
Sure. I'll meet with family members, and we have these discussions. I will sometimes arrange meetings I'm a family physician, so I will make arrangements and sometimes meet with the oncologist and myself and the family members, so we will have a group meeting like that. So we have multiple variations of that within our clinic. I will sometimes I had a patient who has various neurologic issues. She ended up having endometrial cancer. It was doing surgery was a real debate, and so I met with the radiation oncologist and the gynecologist and patient and her husband, and we had a powwow. So, you know, we make those arrangements, and fortunately, I'm in a clinic where I have colleagues who are more than happy to do those things, and we have a good rapport. That doesn't always happen, and it's not always feasible depending on your locations and how far away you are. You know, but of course, you can have webinars. You know, you can have go-to meetings where you can have discussions like that.
And I would say for Anderson, just the way that we're structured, we're what is called a multidisciplinary care practice. So our outpatient centers are focused around disease issues. So we have a breast center, we have a melanoma center, we have a brain and spine center, we have a GU center, GI center, and all of the physicians and or ancillary services that need to be involved in the care are in that center. So you have your surgical oncologist, your medical oncologist, your radiation oncologist. For head and neck, we have dental, speech, audiology, all in the same vicinity, so the patients don't have to travel. The other thing about cancer that you probably all know is that nobody ever shows up alone. So you have the patient and they have their entourage. So it's definitely a group process. The other thing that we feel is unique to Anderson is that we do what's called tumor boards, that we call them multidisciplinary planning conferences for our different disease sites. So like for head and neck, they meet every Thursday at 5:45, the whole team. They're streaming in people from our sites in Orlando, from internationally, and they literally talk about every new patient that they've seen. And sometimes it's, okay, we know exactly what to do for this patient, but if they don't, they actually have a discussion, the whole team's there, and they plan the care. They'll then go back to the patient and their family the next time that they come in, which is usually the next Wednesday. They see new patients on Mondays and Tuesdays. The next Wednesday, they'll come back. They'll say, this is the plan of care. Does everybody agree? Yes, no. What are the limitations to that? So we truly feel like we can obviously do more in terms of shared decision making, but for some things, you know, there's only one way that we're going to go, but that's definitely an area where we're really trying to get more engaged, and actually it's our nursing staff that's been leading the majority of that. They really want to feel like they're the ones that are sort of pushing this more honestly than the physicians are.
Great. I saw a bunch of hands go up for patient engagement strategies too.
Thank you very much. You're both talking about the huge step forward, looking up the EHR when the patient can look what you are doing in the room. Mm-hmm. Do you have any experiences in giving the patients possibility to act on the EHR, or can they react? Can they write something? Is there a patient's room for comments, for notes, for maybe for having a dialogue with the health professionals in the situation or in between the situations in the clinic?
We, in our previous portal, patients were able to update their history, okay? In our new portal, they will be able to do the same thing and then eventually do more. We are thinking about having queues in the waiting rooms where they can do some of that. We're not sure how strategically valuable that's going to be for our particular setting. For some people's settings, that's very useful. So we're playing with that at this point. What we do in the exam room is the patient, I can update it as they speak to me. So I do that in the exam room. And our MOAs actually do it ahead of time for me, but I can update it as we go.
And at Anderson, we do have a place in our current patient portal where the patients can keep a journal, and they can actually send that information to their providers. But I think you touched on something that's huge for us, because the one thing that we, if nothing else changes, this is the one thing, is that we want the patient record to be the voice of the patient. The record's about the patient, everybody's writing about the patient can read about themselves, but there's nowhere in our record where it's actually their voice. And what we really want to have is the patient's voice in the record. And so that's ultimately what we'd like to see at some point in the future.
One more little question more, because you call them patient portals. Do you have any networking places for the patients? Can you, as an institution, bring the patients together, patients with the same diagnosis, which could have positive effects from communicating with each other about the diagnosis? Do you bring them together and do you monitoring their being together?
We've actually attempted to do that in the past, and I actually had to do some digging a couple years ago to actually find where those message boards were sitting. We have something called WarmNet that our institution supports, and I have no idea if it's actually supported by MD Anderson or an outside agency, but we also have what we call our Anderson Volunteer Network. These are all former patients that are available 24 hours a day for patients to call. We do have support groups, obviously, for every disease site that we have, but we don't have, at this point in time, sort of like an electronically monitored space yet.
Any other social media opportunities or social collaboration?
Not at this point.
Okay. Yeah.
Hi, I'm really glad that you talked about meeting people sort of where they are with technology and how to address people who may not want the cell phone, for example. We had a very similar situation in Alabama, which has a very, very dispersed population, many sick, elderly, rural people. And we had a technology firm come in and say, well, we're going to push out text messaging to all of your Medicaid diabetics to help support them. And we said, well, our first question is, have you checked to even see whether they have cell phone service in their town? And I think this isn't a question, but I think it's important that everyone realize that what seems like a good solution when you're sitting in a conference room in Dallas or Atlanta or DC or New York is not necessarily going to work in what's commonly called flyover country.
I completely agree.
That is a great point.
Thanks. I'd be interested from both of you as to whether there's any evidence that you can see that greater patient engagement leads to lower intensity of treatment. In particular at MD Anderson, I'm wondering how hospice care segues from your institutional care and whether part of the patient engagement actually is about that, but also for Ingrid as well. Do we see greater patient engagement leads to less intensive care for patients?
I think, again, I don't think you can divest personality from computer. I think the personality of the physician is still the primary driving force. And honestly, if you've got a dry physician, you're going to have a dry interaction with the patient, whether you've got a paper chart in front of you or a computer in front of you. The personality and interaction of the physician with the patient is still foremost. Now, having said that, I think if you have an engaging physician who really wants to deal with the patients, the computer is only going to make that better. You have to have an imagination and you have to be willing to make it work, okay? And if that's the case, then the computer's going to make it better. If you have an unimaginative physician with a paper chart and an unimaginative physician with a computer, it's not going to work either way, okay? But the computer can make it so much better if you have the will and the imagination to make it so. That's what I'm saying. Yeah. It's a tool, and it depends on the person who's using the tool.
And I would completely agree that the computer's just sort of an enabling platform to engage patients. It's not patient engagement itself. And Anderson being a cancer care center, that's all we do. I think from our perspective, we would say yes, that any way that you engage the patient throughout the care process is going to maybe not lead to a lower intensity of services, but perhaps maybe less volume. It might actually be more intense. I know what you were getting at. But it's really interesting also. So I just left TEDMed. I just got in yesterday from TEDMed, and the last session that I did was 4 hours on end of life. And I have to say, from my perspective, being at Anderson, we really could do such a better job at end of life, and so much time and resource and emotion goes into that period that doesn't necessarily need to be there. And so if we can get patients in the prevention process even talking about these issues, we can definitely reduce the intensity of services. So I would say yes.
Great. And yeah, right.
I'm not going to second that. I've been sitting here and listening, and I'm saying, gee, in the first 6 decades of life, most people are pretty healthy. They may have some chronic disease, but the general population is a healthy population. And when I think of patient engagement, I'm not thinking of the portal alone. That's one piece of patient engagement. A telephone call after a visit from a staff member in the medical center following up is also patient engagement. And what I was thinking about was using the portal. Have we learned from other industries? And so far, I haven't heard, and maybe not just the panelists, but especially Ingrid in a family medicine practice, your population is much obviously healthier than Heidi's population. But from my perspective, I've gone to, in education and in my work career, have been to 6 or 7 university systems. And their development offices, every 6 months or 3 months, send me a letter, would you give to us, and with that little envelope. Most of us have had that same situation, except one. Brown University, where I went to school, they send me a letter about the university. And I actually read that because there's no envelope attached to it. They really want me to know about the university. And I'm thinking, in the patient portal, what if we sent out, after meta-analysis, information to the patient population about, gee, 1 drink a day is good for you, and here's the reasons. Or, you know, this myth or this general wives' tale, or whatever you want to call it, about eating chocolate is great for you. And the whole idea is to send out prevention, just as you said, prevention messages to your population. The portal could segregate it. It could have cohorts. I'm going to send the positive messages about diabetes care to my type 2 diabetes patients, and special messages to my type 1s, or my obesity patients. I could send them this nutritional information and they could find more. But I haven't heard, and maybe this group can tell me, if as we develop our patient portals, again, as one part of patient engagement, are we sending them information that would be valuable from keeping them from coming to us with a chronic disease, or worsening that chronic disease? So that's the general question. Are we thinking beyond our industry of giving them a record? Getting a medical record and a bunch of metrics and tests is great engagement, but it doesn't help them in their, especially the well people, in figuring out what I should be doing to stay out of the MD Anderson.
Well, that's the whole point of these, and that's why we made the switch from our previous computer system to the one we have now, is that we can do all these analyses and all these registry reports, that we can fine-tune and hone in on exactly what our patient population is, and send out that kind of information to our patients and find out exactly what kind of practice Ingrid Antonsen has and where she needs to focus on, what her patient population is, and what her diabetics are doing, what her hypertensives are doing, what her hyperlipidemics are doing, what her coronary disease patients are doing, and where she needs to focus. And so that's exactly what these computer systems can do for us that we haven't been able to do in the past, because there was no way we could monitor all these charts and go through them. And that's what these computer systems really can do for us. And that's where the big boom is for preventative health care. And that's where they really do help us. And that's where they do personalize the care for us. And yes, that's exactly what they could do for us. Exactly.
Actually, over here, I have a question actually about the risk associated with patient engagement. There's obviously a lot of benefits, but for example, if patients are accessing their records, or their parents or their aunts and uncles or whoever's responsible for that care and is changing and updating data, does it incorrectly, what does that mean? Or if you're to your point, pushing out information proactively, but let's say you send an email out or a text message to somebody who has HIV, and then somebody else accidentally looks at that phone or email. Now you've just breached their trust. So while there's no doubting the positive impact of this, I'm wondering if you've thought about or had to deal with any possible risks or
Well,
security incidents.
First of all, when you send out information, you send an email saying that there is information for you in your portal. You don't send information by email. You just send information saying there's something in your portal. Then they have to access their portal via their secure access. Okay, so, and if they give their secure access to someone, HIPAA only goes so far. They have their responsibility. If they give their secure access to someone, that's their responsibility, okay? So, and if someone has PHI, power of health information, over somebody, then they have the right to access that information. Just as if I went home and I told my mother certain information, or so she told me a certain information. There's only so far the healthcare community can go to protect somebody. So this, this is as far as it goes. We don't send somebody in the mail confidential information on HIV status. That's something they usually have to come in for. And we don't send them an email that they open up, that's something they have to go to their portal with that secure information and open that up. And as far as, entering information on the portal, such as changing their address or changing something like that, that they cannot do. That they cannot do.
And just to further address that, I think also just this might be the best time to make this point, is that when I said that people don't come alone to MD Anderson, they come with their entourage, we really are also looking at ways to engage the caregivers in this process, because generally the patient, especially if they have a more severe case, is not going to be the one accessing this information. So we're trying to figure out ways to give secure access to caregivers, because we know that these patients are going to give their username and password to other people. I mean, I manage my grandfather, my father, my mother, my grandmother. I mean, I have access to all of their information because they've told me they want me to have access in case something were to happen, they end up in the hospital, I'm their caregiver. So we really need to start thinking creatively about how do we create information for caregivers as well. I don't need to know everything about my grandfather's history going back to 1926. No thank you, I don't need to know. But right now, while he's doing his methotrexate and he takes it on Sunday, he gets sick on Mondays. That's the pattern that I know. So I want to make sure that I know who to call on Tuesdays if he's having a severe headache or things like that. So really it's trying to think about it in different ways, and how do we really look at the whole patient experience, not just the one that the patient's going through, but everybody around the patient as well.
There's a question in the back, and then we'll.
So I'm finding this a fascinating conversation. What are you doing differently now from a training and talent selection process when you take a look at your docs, you take a look at the primary care or the caregivers and the physicians that are part of that process? How is what you're learning changing how you're training and how you're selecting some of those folks?
I would say at Anderson, I think they're changing us. I think the new generation of clinicians that we're getting are really so much more geared towards technology that they're kind of asking us, well, hey, why don't we have this? Why doesn't everybody have an iPad or an iPhone or a BlackBerry? It'd be so much easier for me if I could do this. I think that's really sort of challenging the paradigm that we have at Anderson of an older generation of clinicians. But I would also say for Anderson specifically, everybody that works there knows our mission, and our mission is to cure cancer. And there's not a single person that works there that does not know that. And so it makes that a different environment to come into. And so it's really sort of a self-selection process. When you come to Anderson, you come there because you really want to work there.
In our clinic, it's been a huge game changer. I mean, in the last 10, 12 years, the way we practice medicine, the technology we use in medicine has been a revolutionary change. And I would say for those physicians who are near retirement, it has been exceedingly painful. A few have really stepped up to the plate, and they're a little geeky and they can manage to change. There have been a few who honestly have retired because they just can't handle it. It's too much change too fast. And those who are coming into practice now, frankly, they've grown up with this. This is what they live with, and why wouldn't we be doing this? So it's in the last decade, it's been a very, very painful change for a lot of physicians who just could not make the change. But there's been no choice. Medicine has to change, and the people who are practicing it have to change with it. So it's been very painful for a lot of physicians who have been the mainstay of our clinic for a long time and been the backbone for our clinic for a long time. And it's been sad to see some of them not be able to change with us.
Great. I'll take one last question in the front and then closing statements.
Do either of you do anything as far as assessing patient activation numbers to check levels of patient engagement? And then the second part is, do either of you do anything related to patient-centered medical home?
We are in the process of applying for the patient-centered medical home, so we're in the midst of all that, in addition to in the midst of switching our electronic medical records. So we're hoping to finish that in the next 6 months. So yes, we're in the process of it, but we're not there yet.
We do monitor the usage of our patient portal and how many people we give logins, and we have seen a tremendous uptake really in the last year of not only unique logins, but then like multiple logins per day or per week. The other thing is you don't want a cancer center to be your medical home. So, we are especially, right, we're sort of, I think we took the approach at the beginning of, we're not really sure how we fit into that model as a specialty center, and we are actively working on that, how we fit into these different models of care that are coming out, because being a specialty cancer center, we're obviously not the only ones that provide cancer care in Houston. So really it's an ongoing conversation with our community partners as to how we're really going to approach the strategy going forward in the future.
Great. We just have a couple more minutes. So in closing, I guess I'd like to ask the panel, if you had all the resources in the world, what patient engagement strategy would you think is most effective and you'd like to implement for your health system or clinic?
For us, what we have just accomplished, which is an integrated health information medical system, which is both the billing aspect and the clinical aspect, which is we have what's called ECW, and it's been a phenomenal experience for us, and it's going to exponentially increase what we are capable of doing in the clinic and take us at least for the next decade forward, which is what we wanted, because we don't want to go through this again. It was very, very laborious, but we did, I think, work well, and the go live went exceedingly well. It could be a very painful process, and actually we all came out smiling at the other end. This is something that I think as a community, the community realized we were doing this, the community realized and our patients realized this was something phenomenal that was for our benefit and for their benefit. I think if you roll it out properly, patients become very engaged and very excited with you that this is something that is going to be for everyone's benefit. And I think if you engage your population properly and make them feel that they're part of the team as well, I think you've got an excitement growing there in the community. And I think we've stepped forward in a very positive way that way. And I think within Champaign-Urbana and with Christie Clinic, we've got that ball rolling, and I'm very excited about it. And I think that's a spirit that a computer system doesn't give you. That's something that you, within your practice and within your patients and within your staff, you really have to build. And if you can do that, then along with the computer system, you've got a forward-thinking process that will take you into the next several years. And I think that's really what you need to look for and you need to engage in. It's not just the computer system. It's the spirit and your community and your staff and how you all work together.
I would definitely agree with that statement. I mean, I think all the money in the world doesn't make up for the fact that there's patients coming in and out every day. All you have to do is go talk to them. They're right there. So.
Great. Well, thank you so much, Heidi and Ingrid. Great job. And I think time for some dinner, right?
Yeah, great. Thank you very much.